So this is, I forget, the 7th or 8th in our series of Lunch and Learns. And it's wonderful to be able to have Brian Baker with us today to talk about how he has been able to advocate for spiritual care in his context at ArnotHealth. He's been the director of spiritual care there for 2 years now.
About 2.5, yes, since the start of the pandemic. So
yeah, and he's a former CPE student. He's completed 4 units of CPE, 3 with us and 1 with Care First. And so it's wonderful to have a student be here to present, and it's also wonderful to have Brian back just because he's an all-around great person and wonderful spiritual caregiver and director. So Brian, I'm going to turn it over to you.
All right, let me see if I can get my screen sharing going here. So first of all, let me just say thank you. Thanks for the invitation. I'm glad to be here, and hopefully this will bring up at least a few thoughts for, conversation and any work that anybody's hoping to do in either establishing or building, maintaining a spiritual care program. So let's see. And you'll forgive me, I'm not on my usual system, so share screen. All right, you should see a little Buddha. Is that what you see? Cool. Okay. So first things first, this is I work in a healthcare setting. ArnotHealth is comprised of several facilities, which is the Arnot Ogden Medical Center in Elmira, the St. Joseph's Hospital, which is also located in Elmira, which is primarily an approximate 75, 80 bed skilled nursing facility, plus an attached addiction recovery unit and behavioral health unit, as well as the Ira Davenport Memorial Hospital, a very small rural hospital in Bath, New York, and an attached the Taylor Health Facility, which is an attached skilled nursing facility with a current resident population of about 100. So my environment's very mixed medical in a number of different ways, everything from some acute care all the way to behavioral health, all the way to skilled nursing. So here's my general thought, and this is something that actually Marianne was very kind to point this out, but it gave us some good terminology. So as you're beginning to advocate for spiritual care within the environment, if you're a manager or a director or just an interested party, the real question is what chaplaincy program is currently in place there. As you can see, I have sort of like red, yellow, and green. I'm assuming that most people who would be listening to this talk are not in the green. If you have a fully functioning professional spiritual care environment with active CPE programs and BCCs all around and student interns and all of that, you're probably in pretty good shape. What most of us are finding, actually, there's also a complete absence of spiritual care in a number of hospitals throughout the country. The last survey that I saw was that approximately 30, maybe even slightly more, have pretty much no spiritual care support in the hospital setting. So if that's the case, if you're an individual who is looking to introduce spiritual care there, you're going to have a lot of work to do. Certainly there are hospitals, actually I know of several hospital systems in the Southern Tier where the healthcare setting itself does not have chaplaincy, but chaplaincy is supported through community means. So collections of churches who have been together in a ministerial board in an effort to place chaplains at least sometime in the hospital. It's a very weak system and they're usually not very fully integrated. So if you're in that boat, there's a lot of work to do. So like I said, so there's sort of the traditional model, and something that I think we still see in a lot of places are there may be a chaplain or a small group of volunteers. In most cases, the staff isn't really trained. Volunteers have minimal training. They're not really integrated into the actual work of the departments. So think of a place where you call someone to come in for a death. So really what's happening there is something very small. I mean, it's an important function, but you're really only contacting a patient or a family at a particular point, death, and only to provide a particular type of usually religious service or religious interaction, prayer, anointing, whatever that thing is. Transitional is, I think, by far the most common thing that we tend to see. Certainly, I believe that that's where we are at Arnott right now. We're very firmly in the transitional phase. So most of our chaplains have some CPE at least. We are integrated with many of the units. We don't really have volunteers so much here, but we do try to, we're volunteers to come on. They would be receiving a lot of base level chaplaincy skills, but not CPE trained. So again, this is that transitional sort of interim area where you're trying to move away from a traditional and toward a professional setting. Now, the goal for here at Arnott is that all chaplains will have CPE training. I would love to see everybody become board eligible. We're working on more fully integrating with all departments. And we're going to talk a bit about what that looks like in the rest of our conversation. And obviously, finally, there's the professional area where, all CPE staff are BCC, all staff are BCC, they're all CPE trained. They tend to have, like I said, active CPE programs. So there's a CPE director and there are interns or CPE interns bouncing about. So in our area, think, someplace like Strong or Syracuse, or usually these are in larger metropolitan areas that have this. But just understand that, in those places, there's usually a chaplain or chaplains dedicated to serving specific units day in and day out. And so they really are part of the healthcare team. They take part in rounding, they take part in the daily debriefings, all of it. And I'm not sure why. There. So, and I want to put in a plug too. There's a lot of different ways. There are materials out there. If you're looking at building and maintaining a program, I know that the SCA, for example, Spiritual Care Association does have a training module that can assist people with this. It can walk through a lot of steps. APC has it too. And there are various settings out there where you can find additional information. So just be aware that, I'm going to be talking specifically what I've done here, but there are actual modules for managing spiritual care departments that are out there that you can look at. It's a paid training. You're going to have to put up some dollars for it, but they might have some more resources and some better guidance for you than necessarily what I'm going to give. Certainly more complete than what I can give in a short talk like this. So be aware that it's out there. So what's the first key that I've done? I think we all want to be able to just go somewhere and ask for money and they give you the money and you get everything you need. As far as I can tell, that almost never happens. And usually it's because if you're in either a traditional or a transitional environment, they don't know what chaplains do. So there's a very strong, there's a need to educate, especially the administration, on the value that chaplains can bring. Like I said, in a traditional environment, if the only thing that they ever see a chaplain doing, if the only thing they expect you to do is to show up in a room, hold a hand, say a prayer, offer a blessing, then they think that that is the sum and total of chaplain experience, right? We'll call you when someone has a particular religious need and for no other reason, which basically means they just don't know what chaplains do. They don't understand the value they're going to bring to the system. And they're going to say, well, why can't their pastor do this? Why can't a ministry care team do this? Why can't a volunteer just do this? And it sort of sells chaplains really short. So just understanding that this education process needs to take place to allow people to understand more of the role of a chaplain. We're going to talk about this in another slide, but right now, I'll just take the most obvious things. What do chaplains do in your setting, right? How do they show up? Are staff able to get them by referral? How are those referrals made? Do they respond by protocol? For example, chaplains in our system always respond to codes. We attend the palliative care team, so we're active members of that team. Is there a policy in place to try to visit all new admits? How are they categorized? How do they round? Is it just a 24/7 call service? So you're not really expecting to see them on the floor. How do you support staff, right? And how do you interact with the interdisciplinary team? And all of these things are just normal things that a chaplain might understand. Administration may not see it. They might never see some of these. But it speaks directly to the question of visibility, right? So if you're part of a palliative care team, then all of a sudden your palliative care social workers, case managers, doctors start integrating with them. If you're constantly on an ICU round or an ED round or a behavioral health assessment team round, then all of a sudden many more staff are accustomed to working with a chaplain, and word gets around really quickly. So something to think about. What is your current environment? What are chaplains being asked to do? And then take an unflinching look at that. There's no other way to put it. You need to know what the current situation is on the ground, because without knowing what current expectations are, you can't really plan. So I'm just throwing this out there right now. Again, administration doesn't really understand often what a clinical chaplain does, as rarely do many people, especially if you're moving from a traditional to a transitional to a professional chaplaincy program. And all I'm going to say here is there are APC resources they're available on the APC website. Beautiful little documents that talk about standards of practice for professional chaplains in both acute and long-term care facilities. Very quick, easy summary. I would highly recommend you give those to whatever your managers, your unit directors, your COOs, CEOs, CFOs, whoever's interested, whoever's going to be a stakeholder in this process. Make sure they understand the full range of chaplaincy services and everything that's done, because you have to start there. You have to be able to clue them in that chaplains are more than just patting a hand and saying a prayer. Okay, this is one of those hard to quantify things. So chaplains have a great downstream effect. And unfortunately, we are generally not seen as a revenue generating department. And so when you're starting to ask for money and you're starting to ask for staff and you're starting to ask for headcount, the real question is why? Well, how many people need it? In a recent study, and I just had this patient visit expectations, you could see that only about 7.1% of people don't want a chaplain visit. So the other 93%, either 65% want a chaplain to show up without requesting it, meaning they show up in the same way that a social worker or an EVS worker or a dietary aide just shows up. That's what they want. And another quarter or a little more want to be able to get in touch with a chaplain if they request it. So the vast majority of people coming into the setting actually would like to see a chaplain and do it and would like to have it in an informed way, right? So one of the things that I know we've struggled with in our environment, and I've heard this at other places too, is that often on admission, somebody asks the terrible question of, do you want to see a chaplain? Which is a really horrible question to ask, because people, again, don't know what chaplains do. Or, they think that chaplains are the angel of death, right? Oh my God, I'm dying, and here comes a chaplain. What's going to happen? And instead of saying, hey, we have a member of our team who can sit with you during this visit, they might be able to unpack some of the feelings that you're having and work with your care team and your family to come up with a plan for you that'll support you while you're here and hopefully give you some strength and resources from when you leave the hospital. Would you like that person to talk to you? I think most people would say, yeah, why not? Give it a shot. But if you just say chaplain, all of a sudden there are all these religious connotations, and it just goes away that none of us really want to go. So these stats speak for themselves. If 90+% of the people wanted a chaplain involved, it just makes so much sense to have them involved in the patient experience right from the get-go, involve them in the care teams.
Hey,
So
Brian.
again, oh, go ahead. Somebody have a question?
Yeah, is it okay to engage?
Yeah, absolutely. Hey,
So-
Tim, how are you?
I'm good, Brian. Nice to see you. Thanks for doing this. So yeah, I was curious. I haven't seen the study. I'm curious to know context on that. Those numbers are very surprising to me. But do you know where that took place or?
Yeah, yes, at the tail end of this presentation, I have a select big bibliography, which will include the link to this very article. Okay.
Awesome. Yeah, I'm very curious to read it. I wonder if that would be kind of universal or if it's very context based. Up here
Well, I think it was, I'm trying to remember if it was done through the Ascension system, but I think it was a fairly sizable healthcare system that did this study.
yeah.
And just again, as a promo, I believe that Transforming Chaplaincy had a talk about that study maybe 3 or 4 months ago. So it's probably available either on their YouTube channel or website as well. So just be aware that there's some other information out there about it. Okay.
Thanks.
Oh, and while we're on this thing, so I can speak to like numbers here generally in the Southern Tier, right? Southern Tier is actually not a big outlier in terms of religiosity in the country today, which means that about 70 or so % identify with a religious or spiritual tradition. So in many ways, if you're not, by not taking spirituality seriously, we really are failing to see the whole person, right? If the hospital or the clinic or the skilled nursing facility really sees a person as a collection of health problems, they're ignoring the whole spiritual side of this person's essence. And again, as chaplains, we know that very often it's not the physical ailment that they're really worried about. It's the emotional consequences of it. They're a single parent and who's going to take care of the child, or they're the primary caregiver for an elderly parent and what's going to happen to them, or I don't want to be a burden on my family, right? All these other questions of meaning are taking place. And these aren't questions that medicine can solve. They're questions much closer to home and they cut right to our heart. And so I think that's a really important thing to remember too. It's not about solving a problem. It's really about accompanying someone on the journey. And, as chaplains, again, we know where this journey will end. It's, another question of how peaceably we'll get there, how much, what comfort will be found, what strength can be found, what acceptance can be found, moving through trauma, all of these things. So, I'm going to throw this out there again. So again, we're not really revenue generating, but so in one of the ways that I was looking at my program was that I really wanted to, start. Staff engagement has been recently, and I know, Tim, you can speak to this too. Staff engagement has really jumped up a lot right now, especially during the pandemic. The question is not, some people say, well, we're there for patients, we're there for patients, we're there for patients. But the truth of the matter is we also really need to be there for staff, because chaplains are force multipliers for the patients by supporting the staff, right? And I did some research in the world of corporate chaplaincy, and I found some studies out there, and I'm afraid I don't have the footnote for this, but so I was seeing that in corporate areas, chaplains, the minimum range for dollars spent to ROI, so return on investment, was ranging from $16 to $16, which means that chaplains are really, really cost effective. In my own environment, what I also know is that, at a time when nurses are getting $15,000 to $25,000 signing bonuses, we know that the cost of retraining an individual or if somebody quits and leaves, often it costs basically half that person's salary to deal with the consequences of that. Which means if a chaplain can either prevent or delay somebody from leaving a hospital setting, just one, in this day and age, that equates to $40,000 to $45,000. And I don't know what your chaplains are getting paid, but that's a lot of money. So, and then it's also the benefit of just the right thing to do, right? So chaplains stand alongside EAP programs, and there are a lot of places where chaplains will talk to us where they won't, or not chaplains, they'll talk to a person, will talk to a chaplain where they might not talk to an EAP practitioner. And we also have the ability to go right into the work setting. So think there's a tragic death in the NICU or in the ED or in the ICU. We can be part of the actual debriefing team that goes in and provides immediate support, right? So we're boots on the ground. And we all know that, so there are two things that cause trauma, right? A terrible event, and then you feel unsupported during it. And while we really can't control the first part, we do have something that we can do in the second. We can make sure that we're with them while things are unfolding, which, you know, yes, therapy, counseling can help in the future, but we can sort of be there to help mitigate some of the immediate effects. And it's a very holy place to inhabit, right? So on the other side, you know, if we have to speak about what chaplains can bring, again, non-revenue generating, there's a lot of cost savings that happens with chaplaincy. And there have been studies that have done with this. And again, I didn't look them all up, but I can find them if needed. But ultimately, we know that chaplains, especially on palliative care teams, the result is like less aggressive treatment options, greater peace, movement people out of the hospital into the home environment for hospice. I know one study showed that in terms of care for cancer treatment, I think it was stage 4 cancer treatment patients, chaplains, if memory serves, resulted in a cost savings of about a little over $4,000 by just having a chaplain involved. So again, not revenue generating, but significant cost savings involved with having us there. But there's no line on him on the budget for amount a chaplain saved the hospital or amount the chaplain saved the family. So it's really kind of tough. But again, you can show all this data. And then of course, increase patient satisfaction scores and referrals, right? The happier a person is, the better their healthcare outcomes, the more likely they're willing to refer the hospital or the skilled nursing facility.
Hey, Brian, did you see the article from, sorry, I can't remember, the Healthcare Chaplaincy Network about having chaplains in the coding system now?
Yes.
Or moving towards that? Oh. Carry on.
Good for you, Tim. Good for you. Tim is a director too, and he knows. So yes, this is one thing I really did want to point out for anybody who is unaware, since this just happened. So the Center for Medicare Services just changed it so that all of those codes that previously had only applied to hospice and veteran affairs now are going to apply to chaplaincy services in any healthcare setting. And those are the changes, right? An assessment by a chaplain, individual session with a chaplain, group session with a chaplain. Now, why is this important? Well, it's important for a lot of different reasons, but most importantly, it'll help chaplains with just tracking what they do, right? So if a chaplain sees a visit, the healthcare code will automatically get coded and we're good to go. What many people, including myself, think will be very likely to happen is that chaplains will be included under the head count for supporting personnel in the care of a patient, which means there's a formula that is applied to the overall billing process, and increasing the head count will actually increase the amount that can be billed to Medicare, Medicaid for chaplain services, or for services in general, but chaplains will be part of it. And if you think your hospital isn't going to figure out a way to charge for a chaplain being there, you're nuts. So it will actually equate to additional dollars from Medicare, Medicaid. It also turns chaplains into a revenue generating department, right? Even if it's a nominal sum, chaplains, again, aren't terribly expensive for what they do. And it can really make a huge difference overall.
Right.
Yes, ma'am.
So how will the hospital, I guess they'll figure out a way, right, to get what's actually happening on the ground into the codes? Like, will it come through the charting, like you chart a
Yeah,
visit?
so my expectation is that so if a chaplain does an assessment, when a chaplain makes a visit, they're going to check a box and it's going to show that they did, Q9001, right? And then if they actually speak with the person and do some individual counseling, they're going to check a box that says they did this. and that will be pulled into ultimately the billing cycle. So, and again, it's not going to be, it's not going to be direct. I don't think it's going to be direct billed to the patient, but it will be billed to Medicare, Medicaid in much the same way that hospice covers chaplaincy as well. That's I think what's expected at this point.
So on this point, I don't know how the back of the house stuff works in our system. It's complicated, but when I saw this come across the ticker, I was kind of excited about it, and I told my VP, and I bumped into our CEO actually, and he said, he sort of disappointed me. He said, "Oh, that's great news, but we haven't done it. We haven't billed that way in years." So I don't know if that's going to have impact here, or if there's, if there's ways or systems that will integrate this more than others. So I'm curious about it though. So stay tuned.
Yeah, I agree completely. I don't know. I mean, it's certainly not going to be a quick turnaround. And given the way that all healthcare systems do their billing and coding very differently, systems will need to be built to accept this, and then figuring out how in the world they're going to do it. So it's certainly not going to happen overnight.
So,
but I take some solace in the fact that knowing that if any healthcare system can get government dollars, they will get government dollars. So they're certainly going to work on it, right? It's going to be an avenue that they're going to explore. And then downstream from that, I think the other thing is if it turns out that the hospital can recoup some of the costs, it will actually incentivize healthcare settings to increase chaplaincy support, right? For those places where money may have really been an issue, this may allow them to hire some of their first chaplains. And for those that are in process, this may again be a good incentive to hire more help. So we'll see where it goes. It may, again, is it going to happen overnight? No. But I too was like Tim, I was excited to see the changes because I know that they've been working on it for quite a while. And it could really have a huge impact in a few years.
well, it didn't make sense that in one situation or one context, chaplains were seen kind of as providers, but in another context, they weren't. So why is that? I mean, a doctor is a provider no matter where the doctor is serving. So if it feels to me like that should also be true with chaplaincy.
Yeah, I preaching to the choir. So it's definitely the case that it should be happening, in my opinion. But again, I think generally there's been sort of this, and Tim, you can speak to this too, there's been this real interest in increasing spiritual support for patients, basically nationwide. So there's more attention being paid, there are more dollars being spent, and I think there's more training and education that's happening. And I certainly see a real interest, especially for those administrators, and I'm blessed, I have some great administrators who understand the value that chaplains can bring and are strong proponents of it, right? And then in the other thing that and I guess it's some of the rest of this, so let me flip to the next stage. So I'm talking a little bit about staffing, right? So what I'm really trying to get at is, that JAMA article that just came out recently, like a month or two ago, there was again a really great transforming chaplaincy discussion on that, and some of it was really talking about full-time employee staffing for a 100-person census. And I chose the one that applied to my setting, since most regional hospitals are under 500 beds. But the number is kind of staggering, right? If you include all the administrative functions and managerial functions, they're suggesting a 3.4 FTE average per 100, which I think is a lot more than most people get, right? I don't know, Tim, what you've got in terms of like your census there, but I'm willing to bet that you don't have 3.4 FTE for 100 people. So, and then if you kind of winnow it down, if you get rid of sort of the managerial function, it's just 2.9. And if you're doing direct patient support, it comes out to 2.2 per 100. So that's if they do nothing other than visit patients, which puts the number at a little about, like 1 to about 45 or so, 40, 45. And I know in my gut, that's about right. When I think about the number of visits that I could do as a chaplain in a day, and I knew how many people that I had in the hospital, it's really somewhere in that neighborhood. You know, not everybody's going to be able to be seen, not everybody's going to be available, but in an 8-hour shift, if I can do 12 to 15 visits, I'm doing an outstanding job, right? But if I have one palliative care case, if I have one death somewhere, I know that I'll be lucky to get into the double digits that day. I would be lucky. And there are some days where I have a couple of those and I've done equivalent of, 8 hours of chaplaincy, 2 visits, right? And so what do you do? And how do you help people understand that a huge chunk of our job is really supporting the staff? I would say on an average day, about a quarter of my time at least is spent supporting staff.
Well, I think on those days when you're doing deaths and palliative care stuff, you're impacting more than one. It's one visit maybe, but if you think about the array of people that you're interacting with, that the numbers will increase. I mean, if you counted.
I'm just saying
family.
that sadly, the way that, how do you track these? Like, if I could somehow get a clicker for every person who I touched in the hospital in a given day, my numbers would be very high. But often when it's like, how many chart notes did I write? And unfortunately, that's often the benchmark is like, well, how many visits did you really make? Well, you're right. I was in one family. There may have been 30 people involved. I've had situations where I've done little services in the hallway for 14 or 15 at a time. I'm sure, Tim, you've been in the same boat where it's just, how do you quantify them, right? What makes a visit? How do you support people? But I know that when I read these numbers, and then I think about the amount of time that I spend in meetings, ethics committee, administrative meetings, management meetings, all the other stuff. I mean, as a director, that's a good chunk of my week. And would I like to be doing more direct patient support? Absolutely. Because that's where I love it. And I love supporting the staff. And it's not to say that I don't love meetings. I'm just saying that there is that managerial function that does take place, whether it's doing payroll or training, whatever it is. But just note that initial, that top line number, that 3.4, that's the part that gets amortized basically over the whole department. So if you have more chaplains, bigger beds, that number gets spread out more evenly. It's just more apparent when you've got a smaller hospital setting, right? Because ethics committee is still ethics committee, no matter what hospital system you're in, you're going to be involved in those things. And then I wanted just to point out, I also have very recently, this was an Ontario study for a long-term care or skilled nursing facility. And they actually came down and made a recommendation of 1 FTE chaplain per 160 residents. Now, obviously, acuity levels will differ, how active the patients are and all of that. But again, what I've seen in our setting is that feels about right. So say, for example, here at the Arnott, up at Taylor, we have the equivalent of 1 FTE now. Well, it's IDMH and Taylor. So, but the chaplains are handling primarily about 100 residents there, but we're also serving the needs of a very small rural hospital, right? So they have a very few beds, but very active ED. And so they're responding to codes and staff support and things like that in the hospital as well. Same thing going on at St. Joe's, where we have 75 to 80 residents at any given time, but we have a fairly active behavioral health unit and we have a fairly active addiction recovery unit. So it's about, a little more than half-time, maybe half-time for the skilled nursing residents. And then the other half is really spent in these other units, which again, have a very high levels of acuity, and a whole lot of staff support is also needed, especially in our behavioral health unit. That can be a very difficult environment for people to work in. And with the pandemic, we've just seen numbers of mental health issues skyrocketing throughout our region, and certainly our addiction rates in the southern tier are just awful. So there's a lot there as well. But I wanted to bring up the staffing benchmarks because once you go back, this is my suggestion, right? How do you make a plan? So you kind of, what I did was I kind of went to my admissions ED, got my skilled nursing census, looked at what we had, looked at our benchmarks and made a comparison, right? So best practice indicates we should have this many staff, when the truth of the matter is that we have a lot fewer. And then what is it that you want, right? Asking what people want. So do you want a 24/7 call calendar? If so, you're going to have to pay for it, right? If you want every new patient screened, you're going to need a lot more chaplains. If you want somebody, RED, it's not uncommon to have more than 100 people coming through there at any point. How much, that alone could be a chaplain's sole purpose, is just being in the ED. So what are those priorities? If you're there as part of that service to people coming in the ED, if you're there supporting the staff during really tough times or surges where they're overwhelmed, what is it that they're looking for? What is the hospital's priority? And I know that from experience is that the moment I place a chaplain in a setting, even if I don't hire for that place, if I put a chaplain in a setting and they start providing service, it becomes routine. And then the staff starts getting that bottom-up pressure of, why is our chaplain not here? And that gets back to administration as well. So helping administration understand what it is we do, getting buy-in for those services, that's one way to do it. The other way to kind of work on it is to do that bottom-up stuff. And this is kind of what I'm saying on this slide, right? How do you make these inroads? What units are going to be your primary stakeholders? I mean, some of them are obvious: ICU, ED, behavioral health. These are very outward-facing areas. A lot of patients are in there. A lot of families are often in there. Palliative care, that's another one, right? So just making your presence known, starting to show up, being as proactive as possible, taking a chance and going in new areas, developing new relationships, really important. So like what we've done here is for example, we worked really closely with LECOM, so the Lake Erie College of Medicine, to provide something for the community, right? So we worked with a chaplain from Guthrie and some other community providers. Marianne, you were one of them, thank you, to basically offer some training for people in communities. And what happened was not only did we get pastors and care teams, we got nursing students, nursing instructors, faculty, people who did family systems for CAs and CNAs. It was a remarkable turnout that we had over 90 people signed up for this event, and outstanding. And of course, many people want more. They want more on understanding spirituality, how they can help with, mental health, more training. There's a hunger out there right now for this. And again, that's something that's the community portion that chaplains can provide, right? So, and again, for our hospital as a not-for-profit, we also have a community mission to provide some of these things. So we're also really engaging with the community and just finding ways to sort of bridge the gap between the clinical and the spiritual. It doesn't need to be as stark as some people want to make it out to be. Really saying, we see you, the whole you, all of you. We understand that this is a spiritual journey as much as it is a physical one for you, and just help make sense of it. And lastly, I just want to say, again, professional and pastoral authority. Marianne, as my CPE instructor, knows this. I used to be a real rule follower, and I guess I still am, but I've definitely come around to being more sometimes of asking for forgiveness. And by that, I mean, when I first was going into areas where chaplains weren't entirely expected, it was easy for me to get rankled because they were like, oh, we don't need a chaplain, or no one here needs, I'd say, does anybody here need to see a chaplain? And they would say, nope, nobody needs a chaplain. And when I was younger, I sort of accepted that as true. But now, after several years of doing this, I know that it's not true. And so instead of saying, okay, all right, and then walking away, I now say, okay, well, then I'm going to start over. Since I now say, who would you suggest I start with? Because I'm going to start. I'm not going to not round on a floor. I'm going to round, and I'm asking for their input. Who do you think needs it most? And if they can't offer one, then I'm going to start with the first door on my right. I'm just going to make my way down the hall. And over time, the nurses see that and they go, oh, well, Mrs. Jones in that room, or Mr. Smith in that room, or, hey, you're back, or, these conversations happen really organically, and they only happen by showing up like consistently. And it's that consistency that's really important. Having a chaplain who's only available to come in rarely in exigent circumstances, while useful, doesn't build the ongoing relationship that is really needed, and doesn't build up that level of trust, to have them say, you are part of the team. We really want you here. Where, routine should be that if a chaplain isn't there, something's wrong. That's what routine should be. Our chaplain should be included in these conversations, not, oh, I forgot to call the chaplain. Oh, I guess we could call a chaplain about this. But it should be, where is the chaplain? Why aren't they here for this? And that's the culture change that we're trying to make. Anyway, so again, I got to look at my time. I know I'm being very verbose. This is that bottom-up structure. What is it that they want? What do the departments want? This is the part where you're going to get a little bit of friction, because everybody's going to want a chaplain, and then you're still going to have to try to prove that it's worth having, right? So again, using those benchmarks in the papers that were provided. And also, I'm finding that for us, there's still that ongoing level of trying to educate all the staff on what chaplains do. I'm very fortunate right now in that when I go in, I'm offered some time at orientation. I get to do a little 15-minute show on what chaplains do and how we're there for the staff. And when I start off on most of those, I usually ask for hands. How many people have ever worked with a chaplain? And usually if I have 30 people, it's usually 1, 2, or 3. I don't think I've ever had more than 3 hands go up. And usually one of them is because somebody was in the military or a first responder and they know that chaplain. Usually the other one is my dad was in hospice, and so there was a chaplain there for that. And very rarely someone's like, well, I worked at another hospital. I knew that we had a chaplaincy program. So educating staff on the value of chaplains and the fact that we're there and what we do is just sort of an ongoing process. And I'm really fortunate to be able to hit people at orientation, but it also needs to take place throughout the system because, for example, our nursing students don't come in through that orientation, right? They come in through the School of Nursing. So how do you get into the Elmira College of Nursing or Corning Community College or Cortland Community College or wherever to have these initial conversations with nursing staff, student nurses, to help them understand what it is that we do? Same thing goes for the residents, right? So with LECOM, for example, being able to give a talk to third-year residents or during their internal medicine or palliative care rotations, when a doctor comes in and sits down with them and talks about end-of-life planning, showing up to that session and introducing yourself as a chaplain and somebody who can help during that process, right? So finding all these little points of connection, because there are a lot of people in the hospital and they come in through a lot of different doors. And certainly there are people who have been here for 2 decades who never really interacted with a chaplain. How do we reach them? Obviously trying to be there consistently is one thing, but raising the visibility of the department, providing valuable information to the care team, like 2 weeks ago, I was like, well, this woman's thinking about leaving AMA. So I went and I spoke with the nursing supervisor and all, like, how do we prevent this? What do we need to do? How can we make her comfortable? How can she understand what's going on? These are all questions. And lastly, like I said, never miss an opportunity to integrate spiritual care. So if they're asking you to try to think about something or do something, I'd really try very hard to do it. And not reacting, but if they're actually reaching out to us for a reason, like, hey, we'd like you to take part in this ceremony, absolutely, I'm happy to do that. And then while I'm there, I'm going to talk about what chaplains do the rest of the time. If employee wellness, it's like, well, employee wellness is really for providers. Well, that's true, but I still wanted to have a table there because I think we're involved in employee wellness. So let's get a couple chaplains down there, introduce ourselves, and talk about how we can help them in their day-to-day lives, or if they're feeling stressed or anxious or upset. No, we're not offering certain other benefits, but we are offering a lot. So whatever you can do to just increase visibility.
Brian, I'm going to
Yes,
ask you
ma'am.
to toot your own horn here a little bit. When you started at ArnotHealth, how many chaplains were there?
When I started, we had less than 3 FTE,
That's including yourself?
including myself.
And how many do you have now?
About 6.5.
And that's in 2 years, 2.5 years.
But again, I've been really blessed to have an administration that's been very receptive. And, when I started, there was no chaplaincy happening up at, I shouldn't say no, but minimal chaplaincy, institutional chaplaincy happening at IDMH in Taylor. So we were really able to open up that space. And it was a difficult time because we did it during the pandemic, but it was also the case that they were very appreciative for chaplains coming. And it was at a time when nobody else was allowed on, right? No visitors, no volunteers, no anything. So there was just a huge need. And it was both sad, and yet it really afforded us an opportunity to cement ourselves in the life of those floors. Same thing in other areas, when at a time when many people were precluded from coming in, and not just our hospital, but any hospital, chaplains really formed a pivot, they were a pivotal bridge to providing information to and from families, supporting patients who were there who would not see their loved ones. So in many ways, the pandemic increased the visibility and increased the visibility of chaplains in general, but also really cemented, in many cases, our role as parts of the interdisciplinary team, because we were there, right? So, the people going into COVID rooms were often the nurses, a doctor, and a chaplain, and that was it.
And so I'm just thinking about time too. How much time do you think in that first year you spent kind of educating your administration and pounding the pavement with them?
That first year was really rocky just because, again, the week that I started was the week the pandemic was declared. And so for the first few months, let's face it, all bets were off. Like nobody knew what they were doing. It was a mess, right? Nobody knew what was happening, how was this going to respond. But I would say once things, quote unquote, settled down a little bit, I think the value was very clear. And I think the education process was just slow. For me, it was very slow and steady. I just kept the drumbeat going. This would be a good place for a chaplain. That's a good place for a chaplain. I'd see a place and I would try to direct resources to it, or I'd go there myself. I was constantly talking to the unit directors, department managers, service line directors to figure out what we could be doing to help support the patients, residents, staff, families, and trying to make judicious, decisions about how to spend that time. But I had my Tim, you can speak this. You got to have your 1 minute elevator speech ready to go, and to just talk about what the value is. And I would preach that every chance I got, on the elevators, to administrators, office staff, doctors, I mean, there were times when I found clinicians who didn't realize that there were chaplains there, or they thought chaplains were just volunteers. And so, doing that, speaking at Rotary or Kiwanis or, like every chance I got in the community, it was really to try to tell people what it is that we do and the value that we bring. And most people are really receptive to it. It's just that they didn't know it existed, or it didn't happen here, or they thought the scope of chaplaincy was much smaller. And so that's just constant, that constant, again, drumbeat of letting people know what it is that we're here to do and what we're trying to accomplish. And I still do it. I mean, it hasn't changed. I still do it every day. So, yeah. Anyway, so I know we're coming close to our time. Yeah. Blah, 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 planning. All right. So there you go. There's the bibliography at the tail end. There, the important stuff for Tim. So there's a lot of stuff there. These are just the ones that are referenced here. I have a much longer list I could give, but these are all fairly new. I have one that's about 7 years old, but that recent JAMA article is huge. And then of course, the expectations article, Tim, that's the one that's from the Journal of Healthcare Chaplaincy. If you have an APC membership, you can access that journal for free. If not, I'm happy to email it to you. I've got a copy. So
Actually, I was going to ask if those links are live links.
they should be.
I'm sad that I let my thing lapse and I have to start over. So if you could send a link, that'd be awesome.
I can send them to you, or I can send you copies of the article.
Oh, that's what I mean. Yeah, if you can send a
Yep.
copy, that's even better, because right now I can't get into APC.
Yeah. So I know I can talk forever. So
Well, thanks for talking forever, Brian. It's so impressive. You're a good salesman. You have great energy. It's impressive, and just so grateful and to see what you've been able to create and what you've done and your energy and the effects of it, the impact. It's inspiring and it's challenging, and yeah, it's such a high bar.
well,
Proud of you.
oh, thanks, Tim. I wouldn't be here without you, buddy.
I know that's true. Maybe that's the best contribution I've made to chaplaincy, is having dinner with you that night.
Yes. For those who don't know, Tim was instrumental in me joining a chaplaincy program. He is a member of my church and has always been a source of inspiration for me. So I'm always grateful for you, Tim. Thank you. So
Brian, I'm so happy that you did this. I think it'll be really helpful for other people, and what you offer here is really amazing, and it's good research grounded work that you've done and making it more accessible to other people. Are you going to send us? Can you send us a copy of?
I'm happy. Yeah, I'm happy to send Marianne. I will send you a copy of this presentation, and then people can do with it what they will.
Okay.
So if it's undersourced or if I'm missing anything, I humbly apologize. But anything that I tried to quote directly, I did at least try to put that here in the bibliography for people. So
That sounds great. So thank you so much. We'll end here. Thanks everybody for coming. Our next Lunch and Learn isn't until January. And Gavia Life Center is going to be presenting, talking about their philosophy and how they address behavioral health in a community setting, and some about their adolescent programs and how they're dealing with some of the fallout of COVID with adolescents. So that will be in January. So this is the last one of 2023. We've had 6 good presentations. So thank you everybody for being here. And especially you, Brian.
well, thank you for having me. It was a pleasure to see you all.
Thanks, Av.
All right. Take care.